Good morning. I want to thank everybody for coming to this webinar. My name is Dr. Dave McCarty. I am currently working as the medical director at a clinical sleep medicine practice in Boulder, Colorado called Colorado Sleep Institute. And I'm going to talk to you today about a subject entitled Patient-Centered Medicine and the FiveFinger Approach to Sleep Medicine Clinical Problem Solving. First obligatory slide is that I have no conflicts to disclose. Some basic housekeeping is that this is a sort of a single direction informational seminar, but you can ask questions. I'd ask you that when they come to you, you can enter them into the QA panel and I will review those questions at the end of the talk. And this webinar is being recorded and will be available on the AASM website in about a couple of weeks. So first of all, in terms of formatting of this talk, I'm going to talk first about something I'll call the identity of the sleep medicine physician. I'm then going to delve into what I call the patient-centered approach to sleep medicine. And finally, we'll get into the FiveFinger approach to clinical decision-making. Sleep medicine as a standalone discipline didn't exist before 2007, at least not the way we know it today. Prior to that time, sleep disorders were investigated by a handful of courageous pioneers who, back in 1975, formed the Association of Sleep Disorders Centers, following a landmark conference in Edinburgh, headed up by the legendary Dr. William Dement. This group formed the basis of sleep medicine as we know it today. Part of the mission of this group was to provide oversight and accreditation of sleep centers, and in 1977, they actually codified standards for this process. In 1984, a new group was formed called the Clinical Sleep Society. Individuals who passed an exam in clinical polysomnography were made fellows of this society. And at that time, there were only 339 members. In 1987, the ASCD and CSS reorganized to form the American Sleep Disorders Association. Again, this was in an effort towards unification of the technical side of sleep medicine along with the clinical side. And in 1999, membership in this joint organization had grown to about 3,500. Again, the goal for this was clinical unification with the technical side. And at that time, the group changed its name to the American Academy of Sleep Medicine. In 2007, sleep medicine finally became recognized as a standalone discipline in the practice of medicine by the American Board of Medical Specialties, with participating specialties including internal medicine, pediatrics, neurology, psychiatry, family medicine, and otolaryngology. So you can understand there's a lot of stakeholders at the table. A few years later, anesthesiology was added to the list. But what does it mean to be a sleep medicine physician? And how do we train people to recognize the complexity inherent in the field? 12 years after mainstream recognition under the ABMS, I believe we're still trying to answer this question. Since its inception, sleep medicine as an entity has always made an effort to become more integrated. And I think this is the reason for the culture of all these parties coming together for a large annual meeting to share information. The pioneers in the field understood how complicated it was. Yet individual training programs, by necessity, sprung up wherever there was a working academic sleep lab, and trainees learned their trade of sleep medicine from their mentors in the field, whichever discipline these mentors had come from. Some programs were situated in departments of neurology, some in Department of Medicine under pulmonary critical care, still others in departments of psychiatry. This construct, by necessity, led to some degree of compartmentalization within the training programs themselves. In an effort to promote greater integration, all trainees are taught about specifics of various diagnoses. We'll get to the International Classification of Sleep Disorders later in the talk. But this leads to what I call a bottom-up form of decision-making, diagnosis-based medicine. And I'm going to argue that this may lead to an incomplete problem-solving behavior on the part of clinicians. Once at the annual sleep meeting, I heard one of the presenters, who is a leader in his field of sleep apnea research, make the following statement in response to a question that had something to do with insomnia. He framed his hands around his thorax and he said, "I'm just a lung doctor." And as if this concept really wasn't something that he was interested or perhaps felt the authority to talk about. And I respect this individual greatly, but I believe that this sort of typifies the compartmentalization of training that we're seeing in some of our training programs. I think the concept of the identity of the sleep medicine physician isn't really a subject of discussion in many training programs. You simply learn the practice from people who seem to already know how to do it. And if you learn from your mentors that the boundaries end at the thorax, you're going to perpetuate this to those you mentor in the future. And I'm afraid that this may lead to stifling of growth. So this lecture is an attempt to frame this discussion and discuss the concept of the sleep medicine physician as having an identity which must ultimately derive from a patient-centered approach. Now, the term patient-centered medicine is something we hear a lot about these days. Practically every major specialty is talking about it. I would argue that it's used so much that the term may start to lose its meaning. People generally understand that it's something that's supposed to be, quote, a good thing, kind of like learning empathy or effective communication skills. But in the end, the impulse among trainees is to hear this term and sort of glaze over and start tuning out, the way you might do when you're forced to submit an afternoon to discrimination in the workplace or something like that training session. I say patient-centered medicine and you say, oh God, when can I get out of here? So this is not my intent. I'm not talking to you today to make you a nicer person. I'm talking to you today about this subject because I believe that it's essential to the problem solving that's required with the types of problems that we deal with. So what exactly is patient-centered medicine? What does it look like? And why is it important for this field? Well, I'll give you an answer in a single word: nonspecific. That's it. Sleep medicine complaints are inherently nonspecific. Even a complaint like snoring doesn't have specificity or sensitivity for the prediction of who will have obstructive sleep apnea and who won't. A primary central sleep apnea syndrome can actually present with socially disruptive snoring. Conversely, a patient with severe obstructive sleep apnea may not make any noise at all. The same basic idea holds true for daytime neurobehavioral impairment symptoms. A patient with mild sleep apnea may present with significant and severe excessive daytime sleepiness, while yet another patient with sleep apnea, which is bad enough to represent a significant independent risk factor for cardiovascular and cerebrovascular repercussions, may complain of no daytime symptomatology at all. Much of your sleep medicine training is going to revolve around a diagnostic procedure. Originally, this was laboratory-based polysomnography. More recently, home sleep apnea testing has entered the mix. And you will determine whether that procedure documents the presence of a specific disease. You'll then spend a lot of time trying to get patients to use therapies that may be impractical or socially burdensome. Under your care, patients will receive specific diagnoses, and you're going to spend a lot of time trying to optimize the control of that diagnosis. This is the essence of a procedure-driven and diagnosis-driven philosophy. The basic problem with this approach is that it falls short of optimal for many patients. To a patient, I'm picturing a satisfying sleep-wake experience like a beautiful stained glass window. When it's intact, it's a thing of beauty. It's a source of well-being and rejuvenation. But when it becomes broken, it could become the focus of that person's life, just trying to get it repaired. So the question really is, what kinds of things can break a window like this? In this example, you can think of obstructive sleep apnea as being a good solid baseball. Most providers have learned to recognize that baseball, and we've even got some tools that can help put that baseball away so it can't be as destructive. But here's the rub. For many people, even when that baseball is optimally put away, the window still ends up broken. So my belief is that the identity of sleep medicine must involve learning how to repair the window no matter how it gets broken. And I think this is the foundation of what being a physician is all about. Sleep medicine has developed its own set of diagnoses, which are conveniently codified in a book that I think everybody should read cover to cover, and you should internalize it and memorize it as much as you can. And that book is called the International Classification of Sleep Disorders. It's currently in its 3rd edition. This is our rule book, and it's important that you know the rules. However, I would caution against falling in love with these diagnostic criteria, as if you over-rely on them, it can make you short-sighted. What these rules forget is that sleep-wake complaints are, by definition, nonspecific. Just because you've got one of them doesn't mean you don't have other problems. And it doesn't mean that the one you've identified is necessarily responsible for the patient's perceived problem. To give you some of the language of sleep-wake complaints, I'm going to list some. And I like to parse these out in terms of what happens during the sleeping time frame and what happens during the waking time frame. So some example sleep-related complaints include, and this is not an exhaustive list, difficulty initiating sleep, the subjective experience of sleep that feels light stage and poor quality, the experience of prolonged endless nocturnal dreaming, which feels exhausting, frequent full consciousness awakenings with the inability to return back to sleep, so-called heavy sleep discontinuity, nocturnal diaphoresis, frequent nocturia, prolonged nocturnal awakenings with difficulty returning to sleep, the development of significant anxiety about sleep for fear of consequences of sleep deprivation, the inability to achieve sleep due to neurosensory discomfort symptoms in the legs, early terminal awakenings, persistent total daily sleep curtailment, nocturnal headaches, teeth grinding, socially disruptive snoring, waking oneself up with dyspnea or gasping, nocturnal pain, waking up from sleep with a disquieting sensation of feeling completely paralyzed, visual or auditory hallucinations at the sleep-wake boundaries, unusual behaviors during the sleeping time frame, such as dream enactment, ambulation, nocturnal vocalizations, or rhythmic movements during sleep. Some sample sleep-wake complaints that can be directly tied to dysfunctional sleep or diagnoses that are typically covered under the purview of sleep medicine. Again, not exhaustive. The sensation of mental fogginess, poor concentration, depression, anxiety, headaches, attention deficit, body aches, morning nasal congestion, sore throat, sinus congestion, frank excessive daytime sleepiness with unintentional dozing, the sudden loss of motor tone in the setting of emotional stimulation, neurosensory discomfort symptoms in the legs when trying to sit still. I think further adding to this complexity is the concept that it's now understood that obstructive sleep apnea may be a contributing factor in the provocation or worsening of many other medical problems. Again, this is not an exhaustive list, but we're getting increasing evidence that OSA exacerbates hypertension, arrhythmias, congestive heart failure, cerebrovascular disease and stroke, migraines, gout, reflux, anxiety, depression, ADHD, vocal cord dysfunction, asthma, tinnitus, and vertigo. So I'll make the argument that having a thorough understanding of the patient's medical history, determining just how important the diagnosis of OSA is for this individual, is an important role that we all must play. The presence or absence of these relevant comorbidities influences your decision to treat and influences the aggressiveness of the therapeutic plan. For example, it may be acceptable to continue a treatment plan such as oral appliance therapy if the apnea-hypopnea index result is suboptimally suppressed, if the patient is satisfied with their experience, and if no relevant comorbidities exist. However, for a patient with inoperable three-vessel coronary disease, a suboptimal AHI result in this setting may prompt you to put the patient through a trial on positive airway pressure therapy in the interest of prevention of cardiac disease, even if they're satisfied with their sleep. Another development in our field is the concept of the chief complaint that's not really a complaint at all. Many patients who present to a sleep disorder center do so not because they have a specific complaint or concern about their own sleep-wake experience. It's at the behest of someone else. These are pseudo complaints, such as, I'm here because my cardiologist told me to come in because I have AFib, or I don't have anything wrong with my sleep, but my wife told me to come in because of my snoring, or I feel fine and I sleep great, but my primary care physician did an overnight pulse ox and said it was abnormal. So in these instances, it's incumbent upon the sleep medicine physician to determine if a given abnormality is actually something that represents a real and genuine health risk to the patient. I'm going to add one more element to this discussion. It's the concept that every medical recommendation you make has an underlying risk-benefit ratio. This is true whether you're recommending a screening colonoscopy, advising that an individual take a statin for the purpose of prevention, or initiating and overseeing an airway management strategy. In all of these situations, it's possible for you to do more harm than good. Positive airway pressure therapy is more than just a nuisance for some people. For many individuals, it can be downright harmful. It can be perceived as a source of considerable psychological distress and can also be physically profoundly uncomfortable. If we're going to ask a person to be saddled potentially forever with a device that has potential to cause harm, we need to be able to explore the patient's experience in a realistic way and help that person discover whether the risk-benefit ratio actually favors benefit. In my career, I've come across individuals who were provided with a treatment plan that just didn't make any sense in light of this discussion. For example, one patient was provided with AutoPAP 5 to 20 through a nasal mask, only to have the experience of retrograde airflow through the lacrimal ducts when trying to use the device. That's what the graphic's about. You see the crocodile with his air coming out of his eyes, and the gentleman above seems to be able to produce that on demand. But think about that for a minute. A treatment that you provide makes air come out of the person's eyes. She was told by the prescribing physician that if she didn't use her CPAP machine, she was going to have a stroke. Now, her apnea-hypopnea index was 6 per hour, and she had no pre-existing cerebrovascular disease. So if this severity of obstructive sleep apnea carries any signal for future cerebrovascular or cardiovascular harm, that signal is soft at worst. So I would argue that such a scenario violates one of the elemental rules of being a physician, the rule of primum non nocere, which means first do no harm. All of the above is a preamble trying to introduce the concept of a methodical approach to hypothesis testing in the field of sleep medicine. And it uses a construct that I based on the FiveFinger Approach developed by W. Proctor Harvey, whom most of you may recognize from his legacy, which is the Harvey cardiac exam simulator. Dr. Harvey introduced the concept that a methodical approach towards cardiac disease can yield refinement in diagnosis. And his FiveFinger approach is pictured on the screen and includes history, physical, EKG, X-ray, and lab tests. During part of my career, I taught a physical exam class to fourth-year medical students, which was designed to give them a better working knowledge of nuances in physical exam technique and prepare them for their future role as medical educators. In other words, I wanted to teach them how to teach physical exam to others. So part of this class involved working with the Harvey cardiac exam simulator, and it allowed me to get more familiar with his teaching accomplishments. At that point, I had recently seen a follow-up patient in clinic who had been seeing physicians within an academic setting for a number of years, and her diagnosis was obstructive sleep apnea. All the notes indicated that the patient was using and tolerating her CPAP machine. No changes were ever recommended. When I saw the patient for the first time, I asked her how she was doing. She said she was doing fine. She was using her machine as she was supposed to. But I was perplexed. Her Epworth score at that visit was still 18 out of 24, which represents a pathologic degree of daytime sleepiness. I began to explore her original sleep-wake complaints. Her complaints at presentation included frequent subjective awakenings at night, and she characterized this as insomnia and a functionally significant degree of daytime sleepiness. Well, several years prior to my first visit with her, she had undergone a diagnostic polysomnogram, and this demonstrated an AHI of 6 per hour, and this established the diagnosis of obstructive sleep apnea. So she was provided with a CPAP machine, and since that time, she was very compliant. She did exactly what her doctors told her to do. The problem was, it never really made her any better. She continued to experience subjective sleep disruption and daytime hypersomnia. However, she was told that treating sleep apnea was important. It was important for her health, so she doggedly continued using her machine night after night. On further exploration, I found that the patient had a rather unusual syndrome. It involved unilateral symptoms of right arm weakness that seemed to be produced by profound emotional stimulation. And over the years, the patient had undergone several imaging studies of the brain out of concern that she was having TIAs, which didn't really amount to anything. Ultimately, long story short, I put the patient back in the sleep lab, and at that point, she didn't have sleep apnea. She had lost 25 pounds since her original study, but instead had findings compatible with narcolepsy. Her unilateral arm weakness resolved following initiation of venlafaxine therapy, indicating that this was an unusual presentation of cataplexy. Now, one of the concepts in diagnostic decision-making that's introduced early on in our training is the concept of Occams Razor. This is otherwise known as diagnostic parsimony. When you're considering an array of different symptoms, this law dictates, the simplest diagnostic solution is usually the right one. The fundamental myth of this has become so pervasive in our culture that many providers really question whether it's true. It's just accepted. And the alarming and somewhat disquieting realization I had was that this philosophy also happens to be dead wrong when it comes to sleep-wake complaints. The problem is that, again, these complaints are nonspecific. And when we're talking about the concept that a stained glass window can be broken by any number of hurled implements, not just a baseball, Occam's Razor just doesn't work anymore. In my experience, most people's windows end up broken for more than one reason. So there's a decision-making term that's known as a search satisficing error. The term satisficing is a made-up word. It's actually, the term for it is a portmanteau, which is derived from a French term which refers to a traveling suitcase. The idea is that two different words are packed together to form a new word that combines elements of both. So common examples that we're familiar with include brunch and smog. So the term satisficing blends the words satisfy and suffice. Essentially, the concept is that one stops looking for an answer as soon as a plausible, simple explanation comes along. If a patient has excessive daytime sleepiness, obstructive sleep apnea satisfies as a plausible solution, and it's sufficient by itself to allow decision-making to stop. It leads to a fundamental decision-making error known as early closure. This is the error that occurred in the care of my patient who ultimately was diagnosed with narcolepsy. So following this experience, I began to think about the nonspecific nature of sleep medicine complaints, and I wanted to develop a patient-centered model, allowing a methodical approach to the sleep medicine patient, one that focuses on the sleep-wake complaints rather than on diagnostic procedures or on individual diagnoses or on specific treatment options. I developed my FiveFinger approach, and I published it as a special paper in the JCSM, and I still use it, particularly when I'm confronted with a difficult diagnostic situation. And now, with this lecture, I'm giving it to you. So my FiveFinger approach is as follows. First finger is circadian misalignment. Second finger is pharmacologic factors. Third is medical factors. Fourth is psychiatric and psychosocial factors. And the fifth are primary sleep diagnoses. And I'm going to take each one of these in turn. So first, let's talk about the thumb. I'll go back one. Circadian misalignment. This is a lecture for sleep medicine fellows, and you're early in your training, so I think this one deserves a little bit more attention. I'm going to talk a bit about something called the two-process model of sleep-wake regulation. So basically, what governs sleep is two separate processes, and the first process is based on the idea of sleep as homeostatic sleep pressure. The longer one remains awake, the more energy one is expending, the more nebulous stuff builds up in the brain, and this causes the brain to be sleepy and groggy. One can think of these substances, this stuff, as being analogous to toxic fumes that build up in the attic. That's why I've got the attic graphic on there. The attic in this case would be the brain. So this happens during wakefulness, and during sleep, the windows all open up and a cross breeze is established and allows ventilation of these fumes to occur. This process is termed process S. And there's many chemicals that contribute to this homeostatic sleep pressure, and collectively these chemicals are referred to as sleep-regulating substances. The best studied of these is adenosine, which ultimately is a breakdown product of metabolism and energy expenditure. Remember ATP, well, used up and adenosine is a byproduct. The caffeine in the coffee you drank this morning is a molecular analog of adenosine, and it blocks some of its soporific effects. But adenosine is not the only contributor to sleep pressure. Other examples include prostaglandin D2 and interleukin 6. There's a lot more, some we haven't figured out yet. The process for attic ventilation is basically an exercise in physical chemistry. A convective current gets established, starting in the cerebrospinal fluid, moving directly through the central nervous system and out through the venous drainage. The fundamental act of falling asleep involves a change in conformation of cells within the central nervous system such that there's a greater degree of extracellular fluid in the CNS during sleep compared to wake. And it turns out for most adults, it takes about 8 hours to effectively ventilate the attic for every 16 hours of wakefulness. Now, the problem with process S as a standalone model for how sleep works is that alone, it doesn't explain the subjective sleep-wake experience that most of us perceive. In other words, you don't wake up in the morning feeling great and then get progressively, incrementally sleepier as the fumes build up in the attic and as the day goes on. And likewise, you don't go to sleep at night. It's not like sleep starts out really deep and then gets progressively less stable as the night goes on, as sleep pressure dissipates. So there's another process at work which helps to stabilize the waking experience and helps sleep remain stable. And this is where the second process comes in. Right behind your eyes, just above the optic chiasm, within the hypothalamus, there's a remarkable paired set of neurons called the suprachiasmatic nuclei. These tiny areas of the brain contains a remarkable and elegant molecular clock, which is the source of your body's ability to generate rhythms of activity of various organ systems, allowing you to adapt to a world that has a predictable light-dark cycle. One of the organ systems under control of this system is the ascending reticular activating system. This is a series of interconnected neurons in the deep brain that are responsible for the generation of wakefulness. If these neurons are destroyed, waking consciousness is no longer possible. If you stimulate these neurons, it results in excitability. Now, the thing about the AAAS that's relevant to this discussion is it's not like a light switch, meaning it's not a binary system. It's not either on or off. You can think of it more like a dimmer switch. And there's many inputs into this dimmer switch that can regulate how brightly the light is going to shine. One of them is the suprachiasmatic nucleus. So on this graphic, you can see the lower arrows are steadily increasing over the course of the day. It turns out that close to the habitual bedtime, the suprachiasmatic nucleus sends messages to the AAAS to turn the dimmer switch up. This happens in roughly the 2 hours prior to the usual bedtime. You can see that that wakefulness input gets much larger. Circadian rhythm researchers have termed this time frame in the circadian rhythm the forbidden zone. And that speaks to the idea that if one tries to initiate sleep during this time frame, it's really difficult to do so. In other words, you have to have a lot of sleep pressure, a lot of fumes in the attic on board in order to overcome the robust activity of the AAAS. Most people perceive this time frame in their cycle as the second wind that can happen after supper. And anybody who's tried to put a child to bed before their usual bedtime with the argument that, oh, we have to get up early, they'll understand the futility of such an endeavor. Not only are their brains full of toxic fumes, which can generate interesting behavior choices when the frontal lobes are not fully developed, but their AAAS is making a definitive argument that they should be awake. It's a recipe for temper tantrums. Now, at the usual bedtime, the AAAS doesn't turn off like stadium lights suddenly shutting down. Instead, it goes around the buoy and it starts to dial itself down in the other direction. Again, it's like a dimmer switch starting to fade. As sleep pressure dissipates across the course of the sleeping interval, the AAAS continues towards its downward descent, and it reaches its low point about 2 hours before the usual rise time. You can think of this time frame as being a, quote, hibernation zone of sorts. Not only is this when the AAAS is at its lowest point in the 24-hour cycle, this is where the body twitch generally happens, and it's the closest we humans will get to hibernation in our 24-hour cycle. The circadian influence on the sleep-wake cycle has been termed process C, C for circadian. Now, the thing about process C that's relevant to this discussion is that the timing of it is always in motion. The placement of the forbidden zone and the hibernation zones can change. So let's take a person, we'll call him Joe Average. Joe Average goes to bed at 10 p.m. and wakes up at 6 a.m. every day. He doesn't even have to look at the clock. At 10 p.m., he just goes to bed. 6 a.m., he just wakes up. What we're saying with this behavior is that his circadian sleep phase occurs at a clock time between 10 and 6. So in this example, his forbidden zone would start at about 8 p.m. and his hibernation zone would be at about 4 a.m. Now, if I shine lights in Joe's eyes anywhere between about 8 p.m. to 2 a.m., the result is going to be that his circadian sleep phase rotates clockwise. In other words, it's going to put pressure on the system to try to make his forbidden zone go later. Conversely, if I shine lights in his eyes anywhere between 2 a.m. and about 8 a.m., the circadian sleep phase is going to be rotated counterclockwise or backwards. What ends up happening is that the timing of process C turns out to be a net result of whomever wins this conversation. The phase delaying influences at the end of the day and phase advancing influences at the beginning of the day. Now, one of the interesting problems that's introduced by this conversation between phase delaying and phase advancing influences is that phase delaying influences typically are more powerful. In other words, if you run the experiment and maximize the amount of light that's happening towards the end of the day, minimize the amount of light that happens at the beginning of the day, it's actually possible to delay the sleep phase by about 3 hours per 24-hour cycle. If you do the opposite experiment, minimize phase advancing or phase delaying influences at the end of the day, maximize the phase advancing, light in the morning, you can only back up the circadian sleep phase by about 30 minutes per 24-hour cycle. So it turns out that some folks are more sensitive than others to the phase delaying influences that happen toward the end of the day. These people know who they are, and they usually self-identify as night owls. So I want to introduce the concept of Zeitgeibers. This is a German word for time giver. Light's a very potent Zeitgeiber, but it's not the only one. Excitement, upright posture, eating, socializing, all of these non-photic stimuli that say daytime can also contribute to circadian sleep phase delay. Now, the reason circadian phase delay is so important as a concept is that many people end up self-perpetuating a problem with their sleep. They'll stay up late watching TV. They'll work on electronic devices. They'll participate in online social media, or worse, they'll keep up with the news cycle. They won't feel tired when they should be going to bed because they've managed to delay their forbidden zone to occur during a time frame when they should be asleep already. As a result, they're forcing themselves to wake up early, possibly in the middle of their hibernation zone, and they feel like it's impossible to get going. They manage this uncomfortable situation using caffeine, sometimes to an alarming degree. They'll muddle through the day with an attic full of fumes, only to come home and have the frustrating inability to initiate sleep when they feel like they need to. On weekends, they'll sleep until noon, and they'll try and make up for their lack of sleep during the work week, and on Monday it starts over. So the reason I made circadian misalignment the thumb of my FiveFinger approach is because I felt it was incredibly important for the provider to have some idea of where a patient's basic biological window of opportunity for sleep is, chronologically speaking. If the patient's main sleep-wake complaint is inability to initiate sleep due to the above scenario, it's pretty unlikely that a CPAP machine is going to solve this problem. More likely, they'll perceive the device as being just another disruption to their ability to relax, and they will reject the therapy no matter how important it is in terms of other areas like prevention. Remember, it doesn't matter to the patient why the stained glass window gets broken. What matters is whether it gets repaired. So determining whether circadian misalignment is present or not kind of requires a bit of detective work. You need to ask the patient about what they're doing before bedtime. You need to ask what they're up to, when they turn the lights out, what time they think they get to sleep. Ask them about their schedules both during the work week and during weekends. Ask them about light exposure, in addition to other phase delaying behaviors such as excitement, socializing, eating, upright posture, exercise. You need to be able to picture what they're doing through their 24-hour cycle. Rarely, people can be born with a genetic defect in the molecular clock, which leads to a cycle that's actually longer or shorter than the day-night cycle of our world. These problems are called non-24-hour circadian sleep-wake disorders. Figure out whether one of these problems is present can be pretty difficult. Usually involves monitoring of the sleep-wake patterns of people who are allowed to follow their natural schedule in terms of when they feel they need to sleep, regardless of the clock. Extended actigraphy, sometimes over several weeks, is the tool of choice for these diagnoses. The second finger of my FiveFinger approach, the index finger, is a critical review of the pharmacologic influences in a patient's life. Polypharmacy is more common than ever in today's medical environment. Many medications are prescribed for non-sleep diagnoses, and these can have a profound impact on the sleep-wake experience. These can be roughly characterized as medications which are insomniogenic, medications which create daytime neurobehavioral impairment, and medications which can exacerbate other sleep disorders. So many medications can promote insomnia. Some medications, and this list is not exhaustive, include statins, beta blockers, many antiarrhythmics, many antidepressants with venlafaxine, desvenlafaxine, fluoxetine, and bupropion heading the list. ADHD drugs, particularly amphetamine-based stimulants, especially those with a long half-life like Adderall. Social drugs that can contribute to insomnia include, of course, caffeine and nicotine. Nicotine is not only a central nervous system stimulant, the half-life of it, being relatively short, leads to withdrawal within a couple of hours, which is physically uncomfortable and can contribute to an inability to get to sleep. Therefore, nicotine kind of gets you coming and going. Alcohol, which happens to be the most commonly used hypnotic agent in the world, it's not a very good one because it can produce sleep that's more fragmented in the second half of the night and typically leads to early terminal awakenings. Many medications can contribute to daytime neurobehavioral impairment. Because of the legal implications of daytime impairment, a lot of these medications come with warning labels with illustrations of groggy eyes saying they can make you dizzy or groggy, but not always. Common examples of medications that can contribute to daytime neurobehavioral impairment include benzodiazepines, dopaminergic antagonists, antidepressants, muscle relaxants such as baclofen, antihypertensives such as beta blockers or alpha blockers, which can lead to fatigue, have been associated with nonspecific cognitive limitation. Antiviral medications such as valsiclovir have been associated with mental status changes, including frank psychosis. Medications can also exacerbate a tendency towards an identified sleep disorder as well. For example, venlafaxine and other norepinephrine reuptake inhibitors contribute to sleep-related movement issues, such as periodic limb movements of sleep and REM without atonia. Frank dream enactment behavior can be provoked by this drug, and this can actually lead to a diagnosis of REM sleep behavior disorder. In patients for whom REM sleep behavior disorder is an iatrogenic phenomenon, I believe the risk-benefit ratio of the medication should be discussed. Most prescription antidepressants, with the exception being bupropion, will exacerbate restless leg symptomatology. Dopaminergic antagonists, such as risperidone, quetiapine, these can severely exacerbate restless legs and make sleep-related movement issues worse. Caffeine and nicotine are also known provocative forces with respect to RLS. It's understood that the neurosensory discomfort symptoms in the legs that are universal in restless leg syndrome tend to get worse when the patient is sleep deprived. In other words, being, quote, sleep replete is one of the most important treatment strategies for patients with restless legs. So if a patient is taking an insomniogenic medication and it is found to provoke insomnia, it's likely to be making the restless leg symptomatology worse as well. Paying attention to the patient's exposure to pharmacologic influences is therefore a necessary component in the complete management of someone with this problem. Opiates and benzodiazepines can directly impact respiratory drive and provoke worsening of sleep-disordered breathing, both central and obstructive. Alcohol negatively impacts upper airway tone and exacerbates obstructive sleep apnea. Now, determining which medications belong in which categories and whether a given social or prescription medication is part of the problem is a challenge. This also requires you to put on your detective hat and a willingness to explore the temporal relationship between the introduction of that medication and the patient's stated problem. Early in my career, I cared for a woman whose chief complaint was traumatically disturbing and profoundly violent nightmares. These all began within the context of a hospitalization, and they went on for months. After some investigation, we determined that her only new medication that was started at that hospitalization was a standing dose of valsiclovir. This was initiated as a herpetic suppression strategy. After a discussion regarding what the risk would be if this medication was stopped, we decided to discontinue it. Her nightmares resolved completely within 48 hours. The patient ultimately determined that the occasional outbreaks of cold sores was a risk she was willing to take as long as she didn't have to suffer from these profound nightmares, which were a tremendous source of psychological distress for the patient. The reason I was ultimately able to solve this patient's problem was by using the FiveFinger approach. The third finger in the FiveFinger approach has to do with the contribution to sleep-wake disturbances coming from other medical problems. Now, the list of potential suspects in this regard is also long. For example, a patient with thyrotoxicosis may complain of insomnia as a presenting complaint. A patient with any sort of chronic pain disorder inevitably will complain of disturbances to sleep as well. Patients who have suffered traumatic brain injury may present with insomnia, hypersomnia, or both. Nocturnal frontal lobe epilepsy can present with symptoms that are misinterpreted as sleepwalking. Nocturnal reflux can present with symptoms of awakening with dyspnea. Vasomotor menopausal hot flash symptoms may only be a problem because they are so destructive to a woman's sleep. The progression of Parkinson's disease can include a disturbed ability to maintain wakefulness, presenting with a clinical syndrome that is indistinguishable from idiopathic hypersomnia. So understanding how much of a patient's clinical picture may be related to a sleep diagnosis such as obstructive sleep apnea and how much is attributable to a competing diagnosis can require a fair amount of discussion. It's also highly relevant to practical decision-making. For example, if the patient ultimately gets a diagnosis of sleep apnea due to complaints of difficulty maintaining sleep, and the problem doesn't resolve with the use of a standard treatment like positive airway pressure, it may or may not be the right thing to do to continue therapy. On the one hand, if sleep apnea is severe enough to represent an independent contributor to future cardiovascular risk, the patient may require education as to why continuation of therapy would be appropriate, even if relief of the original presenting symptom has not been achieved. On the other hand, for sleep apnea that's milder in severity, the physician and patient may ultimately decide that because treatment did not achieve the goals of therapy, it should be discontinued. The fourth finger in this approach is a fairly broad domain and includes psychiatric, psychosocial, and psychological elements. I combined these influences under one domain because there's often so much overlap between the patient's social structure and environmental and general mental health that it's worth investigating. For example, a woman who feels unsafe in her own home due to the presence of domestic violence may present with a chief complaint of difficulty sleeping. Difficulty sleeping is a common symptom in many mental health diagnoses like depression, anxiety, schizophrenia, and ADHD. Insomnia syndromes often have a pronounced psychological component, and much of our current research regarding insomnia management indicates that cognitive behavioral therapy exercises can have a profound and lasting effect in terms of providing relief. Environmental influences like persistent noise, light, and other disturbances to the sleeping environment are also factors. So in order to find out about these factors, you have to ask. Again, the job of the sleep medicine physician becomes a bit like being a detective. Ultimately, you have to enlist the aid of colleagues sometimes within the mental health fields if you feel like these mental health situations are worth individual management. Finally, we get to the fifth finger. So the fifth and final domain in this strategy involves diagnoses that typically fall under the purview of a training program in sleep medicine. And I deliberately placed this domain last, as these diagnoses are obvious and you can read about them in our manual: obstructive sleep apnea, restless leg syndrome, narcolepsy, etc. My feeling was that once you train yourself to recognize other competing elements in your original differential diagnoses, the possibility of a search satisficing error goes down. You then have the ability to have a better understanding of the contribution which is made to the patient's sleep-wake complaints, which is primary, by a diagnosis such as obstructive sleep apnea, and you can plan the aggressiveness of your approach accordingly. Now, in considering this domain, you have to become an expert in the interpretation of the tools of our trade, specifically the interpretation of the raw polysomnographic data that are available with laboratory-based studies and home sleep apnea testing montages. In order to assist the patient in assigning blame for sleep-wake complaints to a primary sleep diagnosis versus competing diagnosis, one must absolutely appraise the original data. It is unacceptable for a sleep physician to review the technical scoring data and write a report from that. For example, a patient with, quote, mild sleep apnea, which is defined by an AHI between 5 and 15, may still suffer significantly from the symptomatic burden of sleep disordered breathing due to obstructive events which fall short of the commonly used 4% desaturation criteria rule for scoring hypopneas. Although the AASM has recognized this and they have approved that non-desaturating events can still have physiologic significance. For example, the arousal rule is part of the current scoring manual. Many insurance carriers don't recognize this, and so many, perhaps most labs continue to use the Medicare 4%. So now let's recap what we've learned. We've established that the natural development of sleep medicine as an identity has come from a culture that has been based on diagnosis-centered medicine, procedure-centered medicine, and treatment-centered medicine, although the governing bodies have been specifically trying to integrate these elements into a single unified whole. I make the argument that individual approaches like these will lead ultimately to many search-satisficing decision-making errors in the era of early closure. We've learned that a patient-centered approach begins first with the patient's sleep-wake complaints, and we need to be able to articulate as specifically as possible what those sleep-wake complaints are. We have reviewed that these sleep-wake complaints can be divided into what happens during the sleeping time frame, what happens during the waking time frame, and we've also learned that some complaints are not actually complaints at all, but rather questions regarding whether an underlying diagnosis may be negatively impacting the patient's overall health, with the patient having no subjective complaints whatsoever. We acknowledge that a diagnosis of obstructive sleep apnea may represent a provocative force for the worsening of other health problems, and therefore a thorough understanding of what these problems are will directly impact our treatment choices. And we've acknowledged that one of the largest challenges in our discipline is that sleep-wake complaints are inherently nonspecific. They're insensitive and may ultimately be attributable to multiple etiologies within the same patient. We learned to see an intact sleep-wake experience as a beautiful stained glass window, which can be broken in any number of different ways, often with multiple implements. So if obstructive sleep apnea is a baseball, we know that there's a bucket of rocks, plenty of other rocks lying around, which can perfectly be capable of causing damage. We know intuitively that it does not matter to the patient why the window gets broken. All that matters to the patient is whether the window gets repaired. We've reviewed the idea that diagnostic multiplicity directly violates the myth of medical decision-making, which is still commonly taught to young clinicians, the myth of diagnostic parsimony known as Occams Razor. The cultural repetition of this myth perpetuates a diagnosis-based approach, leading to missed opportunities to provide treatment. It can also create an environment where the patient, assisted by the clinician, develops an unrealistic expectation for improvement from a single treatment strategy and may lead to abandonment of therapy due to the perception that it's not doing any good, even if that therapy might be a good idea for other reasons, such as prevention. We've learned that once the sleep-wake complaints have been identified and completely characterized, an approach then involves consideration of multiple domains within sleep medicine, such as the FiveFinger Approach. It can help the clinician maintain some order over the problem-solving process in this uncertain environment. Assessment for circadian misalignment involves understanding the basics of how sleep is governed, which involves a complete understanding of how the two-process model of sleep-wake regulation works. Assessment for pharmacologic influences involves a critical appraisal of the patient's medication list, including prescribed medications, over-the-counter medications, and social medications. Assessment for medical influences on the sleep-wake experience involves a thorough understanding of the patient's medical history. Evaluation for psychosocial, psychological, and psychiatric influences involves directed questioning towards these domains and an ability to fully visualize the patient's life within their natural environment. And finally, assessment of the contribution of traditional sleep medicine diagnoses requires that the clinician develop an expert ability to see patterns within complex data sets, developing the ability to personally interpret the actual polysomnographic data beyond what is reflected in the numbers generated by a trained scoring technician. This knowledge is essential if the clinician is to help provide guidance regarding attribution of sleep-wake complaints to primary sleep diagnoses versus competing diagnoses. And with that, I'm going to stop. Looks like we've got several minutes for questions. And I so far have nothing in my Q&A field, so I must have been either exceptionally clear or exceptionally opaque. Here is a suggested reading list, and please feel free to email me. The email address is at the bottom if you care to ask questions in private.